welcome to the 2021 Hospital Summit on Telehealth. We're so thrilled that you're here. I'm going to start with some housekeeping announcements. I don't need to tell you what the bathroom is, which would normally be a housekeeping announcement. Please keep yourself muted and leave your videos off until we get to the breakout sessions. This first part of the day is going to be a lot of speeches and slides, so we want to allow the speakers to have the floor. Please put your questions in the chat. We will be taking questions whenever possible, and so please put them in the chat. The Zoom link that you logged in for today is the same throughout the day and tomorrow. And this particular morning session is open to press and is on the record, but the breakout sessions are off the record. We want to make sure that that everyone has a sort of an open forum to discuss how things are really going without worrying about the press. I'm going to pause for a second because I think that my colleagues are telling me that I'm having some display issues. So hold on one second.
I think that you were looking at my ceiling. I'm hoping that this is better. Okay. So again, I guess as you can see, we're still working out our kinks here. And so we're going to aim to produce a white paper coming out of this meeting. So in the white paper, to the extent possible, we want to focus on policy. It will obviously address operational issues that are challenged because of policy barriers. And so we're hoping that these breakout sessions can unearth some of those topics. We will be recording the event for purposes of the white paper, but the recording of the breakout sessions will not be made public because, again, just as I mentioned before, we want to make sure that people can speak freely. And if you wish to speak during the breakout sessions, you're welcome to do so and unmute yourself. And then, of course, the all-important Twitter handle. We're at Connect with Care. So if you'd like to tweet during our session or follow us as we're tweeting, that would be terrific. So the agenda today, I'm going to speak for a little while and just give a state of play, and then we're going to hear from a senior official of the Biden administration, Kristen Link-Young. She is actually an advisor to the president and deputy director of the Domestic Policy Council in the White House. We're going to hear from Senator Roger Wicker, who is a longtime telehealth champion and the co-chair of the work group in the Senate. And we are going to hear from Chairman Mike Thompson of the House Ways and Means Committee, also a longtime champion and the co-chair of the telehealth or the telehealth caucus in the House. Both of these members of Congress are going to get an award from us today. They have been, as I mentioned, working very, very hard for a long time, pre-pandemic and during the pandemic, to ensure access to telehealth. So their constituents will be awarding them the first ever Digital Health Congressional Champion Award. And then we'll go into our breakout sessions. So we have one breakout today and 3 tomorrow. The new thing with Zoom is that we don't have to jam a whole bunch of breakout sessions back to back and concurrently. So you can come to the ones that you want to come to. They won't be overlapping. The first one is Bill Beniotti from Intermountain. He's a critical care physician there and also the head of telehealth services. The senior medical director of telehealth services, and he's going to be talking about improving access across the digital divide. On the next day, we have Dr. Bali Yahia from Ascension. He's going to be talking about the consumer engagement in virtual care. And again, I say talking about, but he'll open it up and it'll be a group discussion. And then Dr. Topher Sharp from Stanford Healthcare will talk about hardwiring virtual care transformation. And then finally, Dr. Ethan Booker, the medical director of the MedStar Telehealth Innovation Center, will talk about cross-state licensure and licensure portability. So we are hopeful that you'll join these sessions for what we hope will be a robust discussion. So before we start, I just want to level set, and I'm going to throw a lot of information at you, and my slides will be available online because I do want to talk about the state of play at the federal and the state level. But first I want to introduce the Alliance for Connected Care for those of you who are not familiar with us. This is our membership, our board membership, and I didn't have it on here, but our website is connectwithcare.org, and we have a list of our members and then a list of our advisory board members. We have a robust network of advisors who we work with regularly, mental health groups, the PAs, NPs, the physicians, a lot of the consumer groups representing people with diseases like MS, Parkinson's, ALS. And so we think it takes a village to get things done, and telehealth impacts a lot of different constituencies in different ways. So we try to really work with a very broad tent. Our website, as I just mentioned, connectwithcare.org, has a lot of resources. So we hope that you'll visit us. Here in the upper right-hand corner, you can see we have a weekly update. So if you're not already on our newsletter, we have a newsletter every week because basically updating you on things going on in Washington and in news clips, etc. And then under our resources, we have a telehealth legislation tracker. There's a lot of legislation at the federal level. We have a data collection page for those of you who are willing to share data. And then as polling and new studies come out, we list those. And this section here, the telehealth for 2019, is a lot of the policy that changed during the pandemic. So we encourage you to check out our website. So before we talk about what changed during the pandemic, I wanted to highlight what barriers there were prior to the pandemic that limited the use of telemedicine across all markets, Medicare, commercial, and Medicaid. So the statutory and regulatory barriers, I think the one that you probably hear about most and talk about most are the site and geographic restrictions in Medicare. A patient has to be in a rural area and in an institution for the provider that is serving that patient to be reimbursed for telehealth services. Obviously, this is not true during the pandemic because we're operating under a waiver, but under normal circumstances, the law has significant site and geographic restrictions. There are also limitations on telehealth codes. New codes are put into the physician fee schedule every year, and it was a short list prior to the pandemic, but it's not all Part B services, for example. So there are Medicare restrictions on federally qualified health centers, rural health centers, and critical access hospitals that need to be addressed. There are Medicare restrictions on modality. So for example, I'm sure that many of you probably talked about audio only telehealth. It has to be audio visual under the law that is not under the waiver. And then there are restrictions on provider type and scope of practice. So physical therapists, speech therapists, occupational therapists are not permitted to bill for telehealth under the statute. Beyond Medicare, there are restrictions in health savings accounts and accepted benefits that I'll talk about. There are issues at the state level with Medicaid, licensure portability, and definition variations. And then broadly, there is a broadband availability problem in many areas and prescribing restrictions. So I'm going to go into more detail on these statutory barriers, but before I do that, I want to also add that we have perception barriers. So when we talk about removing statutory and regulatory barriers, it sounds easy, but we're up against some pretty significant perception barriers. So one of those is that lifting the restrictions in Medicare will lead to unnecessary utilization. There's another one that telehealth is really just for urgent care and behavioral health. There's a perception that telehealth is uniquely subject to fraud. There's a perception that patients aren't seeing their own doctors and that continuity of care could be compromised. And there is a perception that Congress is not going to let these flexibilities end, that once Congress gives beneficiaries a benefit, they don't want to take it away. So these perceptions are barriers to us being successful on Capitol Hill, and I'm going to talk a little bit about these after I go into more detail about the statutory and regulatory barriers. So in March of last year, March and April of last year, there was a mad scramble to ensure that patients had access to telehealth given the lockdowns. Congress passed broad legislation that would allow Medicare to pay for visits via telehealth across the country in the locations that were outside of rural areas and including patients' homes. This immediately opened up a lot of opportunity, as I'm sure that you experienced in your own health systems. I'm sure that the graph, I was debating whether to put the graph in of showing the exponential increase in telemedicine visits, but I assume that if you opted into a Telehealth Summit, you probably have seen a variation of that graph in your own system or previous presentations. So I think we all know that there was an exponential growth in telehealth visits among Medicare patients and other markets as well. The legislation that Congress passed also allowed CMS to permit a wide variety of different kinds of practitioners to practice telehealth, including PT and OT. The Congress also passed permission for the audio-visual telecommunications modality requirements to be relaxed so that we could have more audio-only use of telehealth. CMS had already, by the time Congress gave them that authority, added payment codes, audio-only payment codes to the list of permitted telehealth codes. But Congress's authority basically allowed CMS to go further. There are now 80, or I think actually more than 80 new Part B codes. Now, risk adjustment was allowed by telehealth for Medicare Advantage. Physician supervision could be done virtually using real-time audio-visual technology. There was a waiver of the HIPAA requirements so that FaceTime, Skype, even Facebook Messenger could be used for telehealth. The HHS Office of Inspector General also granted flexibilities around waiver of copays. And so there was a lot of zero copay visits that were happening in the early part of the pandemic. And they also removed some established relationship requirements, which I'm going to talk more about later. Established relationship requirements are a real concern for us. And then finally, they allowed for payment to FQHCs, rural access hospitals, which is not added here. And then finally, the DEA allowed for prescribing substances by telemedicine. So a lot happened in a very short amount of time, and that is, because of that, is what we're seeing in the market now. So this is just an example of some of the new codes that were added to the telehealth list. That code list had been added to very incrementally year by year, but it increased exponentially at the beginning of last year. We now have a third of fee-for-service payments in Part B eligible for telehealth reimbursement. And for some specialties, that's up to 90% of the codes that they use. So you can see here, there's a significant use of telemedicine among primary care, endocrinology, pediatrics, and even some that you wouldn't necessarily think of, like OB and urology. Medicare Advantage similarly had waivers put in place, although there's already significant flexibility in Medicare Advantage. The CMS allowed for reduced enrollee cost sharing. They allowed for any geographic area to be covered by Medicare Advantage plans, and they allowed for the prior authorization requirements to be waived. One thing you probably don't hear a lot about is in the commercial market, health savings accounts. Health savings accounts are coupled with high deductible health plans. They are a tax-free account that people can put money into to pay for medical services. And these health savings accounts have to be coupled with a high deductible health plan. So the high deductible health plan in 2020 was defined as a $1,400 deductible for a single person and $2,800 for a family. The problem is that you can't, under previous law, you cannot access telemedicine as first dollar coverage until after you've met your deductible. So you have to pay full price for a telemedicine visit, and your employer cannot subsidize that visit. Many employers have previously been offering subsidies, essentially. I mean, you could have a $5 telehealth visit or a $0 telehealth visit because employers were wanting to offer that benefit and facilitate that benefit. Employers couldn't do that with people who have HSAs because it's considered other coverage, and that is not permitted under the statute. But in 2020, last year, when the CARES Act passed, Congress created a flexibility whereby employers could subsidize telehealth in HSAs until the end of this year. So until December 31st of 2021, an employee with a health savings account can get free or reduced telemedicine visits. As I mentioned, the DEA basically created an ability to prescribe certain controlled substances over telemedicine as long as there were some conditions met. Extremely important for treating mental health conditions during the pandemic. And the Alliance for Connected Care and other groups around Washington have been working hard to push the DEA to create a permanent process whereby providers could prescribe across state lines using telemedicine, or excuse me, by telemedicine, because obviously there's a lot of people with mental health and substance abuse disorder who are having to drive long distances to get care, and prescribing over telemedicine is an important advancement that has occurred during the pandemic that we want to keep in place. Okay, so basically I've told you what the barriers are, what happened during the pandemic, and here we are now in almost getting close to the middle of 2021. The Department of Health and Human Services has said that the flexibilities from the public health emergency will remain in place until at least the end of this year. So where does that leave us in terms of what we should expect for the rest of the year? There are multiple bills in Congress, and the first here is the Telehealth Modernization Act. We are very bullish on this bill. It removes the geographic and originating site restrictions in Medicare. It encourages CMS to consider other professionals to offer telemedicine, and it also codifies the codes that were already in place that were expanded during the pandemic. So we're excited about that one. Chairman Mike Thompson of the House Ways and Means Subcommittee on Taxation has introduced a bill protecting access to post-COVID Telehealth Act. These are the provisions of that bill. We're going to hear from Chairman Thompson today about the prospects for this bill. It is bipartisan and has support in the House and solves many of our problems. And then there's the Connect for Health Act, which many of you have probably are familiar with. This bill has been around since 2016. It will soon be reintroduced by Senator Brian Schatz and Senator Roger Wicker, who we're going to hear from later today. It provides the Secretary with waiver authority. Now, we obviously would like to have a complete elimination of the originating site and rural restrictions. This bill does remove the rural restrictions, but it does provide the Secretary with waiver authority to get rid of the originating site restrictions, which is an additional extra step, but it is certainly a step forward from the previous law under pre-pandemic law. So those three bills are probably what I would consider to be the telehealth bills in Congress. As I mentioned earlier, we have a list of all of the federal telehealth bills on our website. But these three bills are really where we're focusing our time and effort, and welcome all of your support in lobbying to pass legislation this year. Before I get to the prospects for legislation this year and what we need to do in order to make that happen, I just want to go through a couple other areas, and I have 8 minutes, so I'm going to speed up here. The accepted benefits, this basically would allow full-time employees who are not enrolled in a health plan or part-time employees or seasonal workers to access telehealth. So this would be an expansion of telehealth benefits to employees that don't necessarily participate in a employer health plan. HSAs, as I mentioned, we want to continue the flexibilities that were allowed in 2021 beyond this year. And while we don't have a bill introduced yet, we have a couple of sponsors lined up. So we're hopeful that this bill will be introduced soon. And then, of course, broadband is an important issue that we need to continue to lobby on. These are just a couple of bills in the House. And then, of course, broadband is being considered as part of the infrastructure packages in both houses of Congress. And obviously, we can't do any of this without robust broadband. So we don't want to forget about broadband when we're talking about Medicare policy and commercial policy. The Federal Communications Commission has also been very active in deploying broadband, or at least deploying funds to enable broadband across the country. They initially allowed for 200 million and just re-upped for 250 million. And I'm assuming we'll keep appropriating more funds for FCC to expand broadband, but to ensure the entire country has access to broadband, I think it's between 80 and 90 billion. So 450 million is a lot of money for sure, but we really need a significant infusion of funds to make sure that the entire country is wired. Okay, so back at the beginning of my presentation, I mentioned that we have a lot of perception barriers. So I want to quickly go through how we want to basically break or dispel these perception barriers. We are not going to be successful on Capitol Hill unless we do this. So the first one is overutilization, that somehow telehealth is going to increase utilization and inappropriate utilization. It's absolutely essential that we dispel this myth. And so we encourage you to provide your utilization data. I actually want to share a slide here from Stanford that essentially helps us show that telemedicine visits are substituting for in-person visits. You can see that as video visits go up, in-person goes down, and vice versa. So we want to really make clear that there is a substitution effect for telemedicine. Second, no-show rates. We want to, and this doesn't necessarily have to do specifically with overutilization, but it has to do with cost, that we want to show that people are less often, they're showing up for their appointments more frequently, and the no-show rates are going down, and therefore they're adhering to their care plans. And the Congressional Budget Office will say that if you adhere to your care plan, you're going to have better outcomes and lower long-term costs. So the no-show rates are important to share with Congress because, again, we believe that the Congressional Budget Office will look favorably upon that. Post-discharge transition codes, we have evidence that these transition codes are being billed more often using telemedicine, and transition codes are associated or correlated with a reduction in hospital readmissions. So if we can show that telemedicine is actually helping to reduce hospital readmissions because transitions are easier to do through telehealth, that data is really useful. And then finally, skilled nursing facility transfers is very useful because we can show the Congressional Budget Office that we're saving money by not necessarily having to transfer patients from a skilled nursing facility to an emergency department as frequently. So this is data that will be helpful to us in dispelling the overutilization, but also the cost myth. Dispelling the myth that patients are not using their own doctors. So this is data that came from a Vizient report earlier this year that talks about patients using their own doctors. And so as you can see here, the blue line is patients using their own doctors. And so this, I think, is a surprise to policymakers who think that patients are going all over the place and seeing whoever, and there's going to be a risk of a care coordination problem. And so one of the things we've been working to do is to say, look, patients are seeing their own doctors, and we don't need a requirement for an in-person relationship, because if they're not seeing their own doctor, it probably means that they don't have access to their doctor and need to see someone or are a new patient. So we definitely don't want to have any relationship requirements, and we're sharing this data as evidence that when patients can see their own doctors, they likely are. Dispelling the myth that telehealth is only for urgent care. I know this is extremely difficult to see. This is data that was released earlier this week from the COVID-19 healthcare task force, and I believe this survey is on our website. If not, we'll put it on our website. But one of the questions that they ask is, what kind of care did you receive in your most recent telemedicine visit? And as you can see, we're going a lot far beyond urgent care behavioral health. There's chronic disease management and acute care being treated by telehealth. So this is important data to share with Capitol Hill to dispel the myth that we're only talking about urgent care or behavioral health. We have to dispel the myths about fraud. This was a flyer that was distributed by the Department of Health and Human Services, Office of Inspector General last year, that created a lot of perceptions that somehow there are telemedicine executives that are these criminal masterminds. And in fact, this was referring to a scheme that had nothing to do with telemedicine. It was a durable medical equipment fraud scam using telemarketing. So back in February, the Office of the Inspector General issued a statement. This is a paragraph from that statement that basically says that telefraud is not telemedicine, that these perpetrators of fraud were billing for durable medical equipment and genetic testing, and that in fact it was telemarketing, that not telemedicine. So we're trying to break down the myths around fraud. I am running out of time for my telehealth state developments. So maybe I will come back at some point for the state, because I don't want to keep Kristen Lake Young waiting. Just checking in here. Okay, so she's not on yet, and they'll let me know when she's on, so I'll just keep going. So states at the beginning of the pandemic declared state of emergencies, which allowed them to waive all kinds of different laws at the state level, much like at the federal level. I'm going to focus in on a few examples. I mean, this is basically just showing the breadth of the things that states waived. But I do want to focus in on a couple of things. One is state licensure requirements. So 50 states waived licensure requirements and in some form. And this has been a major priority for the Alliance for Connected Care. So actually, this goes back a slide here. There were 706 bills introduced in the 2020 session of 2020 and 2021 session. And 543 of them were, and also 543 regulatory actions. So state telehealth activity was significant last year. But again, I'm going to focus in on the cross-state licensures. So these states had some form of cross-state licensure bills in this past session. And there was a significant variation in the approaches to licensure portability, but all were trying to facilitate more cross-state licensure. And I do have a bunch of slides left, but Kristen Link Young has just joined us and I don't want to keep her waiting. So I am going to go ahead and pause my presentation and come back to it. And again, my slides will also be online. Welcome to Kristen. She is the Deputy Assistant to the President and Deputy Director of the Domestic Policy Council for Health and Veterans Affairs. Before joining the White House, she served as a health advisor for the Biden-Harris transition team, and she was a fellow at the Brookings Institution where she focused on health insurance. She's also been a deputy secretary at the North Carolina Department of Health and was in the Biden administration where she served as HHS as the principal deputy director for CSIO, and also served on the Domestic Policy Council, the Office of Health Reform, and CDC. So obviously very lucky to have you in the White House, so well qualified. Thank you for joining us, and I'll turn it over to you.
Great, thank you so much. And sorry, my lighting is like not ideal in this spot, but we'll make it work for now. So thank you so much for that, Krista. I'm Kristen. So I sit here at the White House and I lead health policy within the White House team. I'm part of the Domestic Policy Council, which is one of the three main policy teams in the White House. The others are the National Security Council and the National Economic Council, and we sort of together drive policy making across federal agencies consistent with the president's vision. As Krista said, I spent the Obama administration working on passage and then implementation of the Affordable Care Act, and I'm delighted to be back in government working to implement President Biden's agenda to promote health and well-being. So before sort of diving in on telehealth, I want to spend just a couple of minutes talking about some of the sort of president's framing for the challenges that this administration faces and the work that we are trying to do. So the president has talked about the 4 crises that America is facing. First is the COVID crisis. We are making progress, but there are still far too many Americans dying, and we need to marshal every resource we can to beat the virus. Second is an economic crisis. COVID has caused massive economic disruption across the country, and we need to help American workers get back on track. This is also a really important opportunity to build the economy that Americans deserve. It's not just about returning us to where we were in 2019, but really building back better. And part of that is fundamentally about healthcare. It's restoring the basic promise that if you work hard, you should be able to get ahead, and that includes reliable access to healthcare for you and your family. We face a third crisis around racial justice. We are in the middle of a national reckoning on race and equity and the tragic cost of systemic racism, and that is part of everything this administration does and very much how we think about the moment in which we have been called to serve. And finally, we face a climate crisis. Radical intervention is needed to maintain a livable planet for my kids and your kids, and that is an obligation that this administration takes seriously. So your institutions play a critical role in facing all of these challenges. So I just want to briefly talk about what we are doing around COVID, the economic crisis, and racial justice, and then sort of dive in on some of the more telehealth specific issues. So let me start with COVID. This is not the work that I lead here at the White House, but it's obviously a critical priority for the entire administration. The president has spoken about what the pandemic has taken from all of us over the last now more than a year: lost lives, lost hugs and first dates and dances, and lost learning in this really brutal year for America's kids. After what I'm sure has been the most challenging year on memory for all of your institutions, I hope that you are starting to feel the tide turn as progress to beat the virus accelerates and we get more shots in arms, and get more work done in communities across the country. There is absolutely very much there is more work to do, and we remain head down, focused on getting that done. But are pleased to see the progress we are making, and again, hope you are feeling that within your institutions and in your communities. So I would say a little bit about the economic crisis and rebuilding an American economy that works for everyone and lifts up those who have been left behind. Supporting workers through the current crisis is a key priority for us. With the signing of the American Rescue Plan last month, we are proud to report that help is here for American workers. The American Rescue Plan means resources to carry out an ambitious national vaccination plan and continue to make progress on the COVID crisis. And it also means immediate financial relief to families that are bearing the brunt of the COVID-19 economic crisis. $1,400 checks to families across the country. We've extended unemployment insurance to provide a critical lifeline to families in this very difficult period. We increased the child tax credit and the earned income tax credit, reforms that will together cut child poverty in this country in half. A meaningful accomplishment that we are very proud to be implementing to make progress for American families. We provided emergency funding for state and local governments that we hope is supporting the work that you all do in your communities and supporting critical programs across the country. The ARP also includes really important investments in making sure that Americans have access to affordable health insurance. President Biden has made very clear that he believes healthcare is a right and not a privilege, and that's why he fought so hard for the provisions in the American Rescue Plan that have dramatically expanded the affordability of health insurance. Financial assistance under the Affordable Care Act has become much more generous because of the American Rescue Plan. No one pays more than 8.5% of their income for health insurance. It's an average savings of $50 per person per month. And about 80% of current enrollees at healthcare.gov can now get a plan for less than $10 per person per month. So really tremendous step forward to make healthcare more affordable for workers, and one that we are extraordinarily proud and lucky to be implementing. The president has also announced the components of his American Jobs Plan, his vision to build back better and create the economy that Americans deserve. I want to highlight sort of two investments from that plan that I think are particularly relevant here. The first is a $400 billion investment in home and community-based services so that seniors and people with disabilities can get the care they need in the setting that they prefer. And this workforce, who is primarily women of color and many of whom live in poverty, can get the raise and benefits that they deserve. We look forward to continuing to work with Congress on the details of what this $400 billion investment looks like, but are excited to be working to transform delivery of home-based care for folks. The other piece of the American Jobs Plan that I want to lift up in the context of this conversation is a big investment in broadband. I expect you all will be spending a lot more time talking about access to broadband as a critical component of the future of telehealth and remote monitoring. And we think the investments we've laid out in the American Jobs Plan are a bold vision to bring high-speed internet to families that are currently left out and really build the foundation that our families, but also our institutions need to participate in the modern economy, and look forward to sort of continuing to talk about the broadband investments. I will say all of this legislating is paired with regulatory work to expand access and affordability of health insurance during the pandemic. This administration opened a special enrollment period to help people get access to health insurance. Any consumer who doesn't have insurance can come to healthcare.gov today and enroll. In just the first 6 weeks, more than 500,000 people were able to sign up. And we look forward to continuing to build on that tremendous progress and get more people into coverage. We're also working hard to strengthen the Medicaid program using all of our tools. We believe we should run a Medicaid program that is beneficiary centered, where the application and enrollment process works better and beneficiaries have access to the care they need in their communities. And we're focused on really lifting up and strengthening the Medicaid program using all of the tools at our disposal. So finally, I just want to say a few words about the crisis of racial justice and health equity. This is something that we take very seriously. Race and place matter a lot for health outcomes, as you all know, and nowhere are we seeing inequity exacerbated more than with COVID-19. Black, Latino, and Native Americans are dying at more than double the rate of their white counterparts. And we have seen some troubling gaps in vaccine access emerge in recent months. In his first 48 hours in office, the president signed 3 key executive orders that speak to our commitment to addressing racial equity and closing equity gaps. First, we've established a whole of government initiative across the White House and our federal agencies to address equity and support underserved communities and redress systemic racism in federal laws and policies and within our programs. And so that is work that is ongoing every day among the entire White House staff and what we call on all of our agency leadership to do as well. Second, we established a health equity task force to address COVID-19 related health and social inequities, and really think of that work as starting in the COVID-19 environment, but building a foundation that will support our efforts to address racial justice and issues of equity in healthcare more broadly and beyond COVID. And finally, we've directed federal agencies to expand their data infrastructure to improve data collection and reporting for high-risk populations. Again, sort of starting in the context of COVID, but really going beyond. And so those three executive orders sort of form the foundation for the work we are doing around health equity. In addition to ensuring that we reach communities of color with respect to vaccine uptake and monitoring the impacts of COVID and running a federal response that takes equity very seriously, we are also working to advance equity outside of COVID. And so that means investing in the public health workforce, including community health workers who often come from the communities that they serve and provide critical lifeline services. We think of achieving mental health parity as a key racial equity issue. We are very focused on reducing our unacceptably high maternal mortality rate and the racial equity implications of our tremendous racial gaps in maternal mortality. And we are committed as an administration to defending healthcare protections for everyone, regardless of gender identity, or sexual orientation. So a sort of big and bold equity agenda to drive health equity and drive equity and outcomes across our healthcare program. So I want to turn now to the subject of your work today, at telehealth and the work we are doing in this space. As you know, as the reason you have all been called together today is to have a conversation about the fact that telehealth changed dramatically during the last year. Providers were forced to rethink the way they were delivering care basically overnight, and federal and state regulators tried, mostly successfully, we hope, to keep up with those changes and build a payment and regulatory infrastructure that could support the flexibility and creative thinking that was going on in systems across the country. Medicare and Medicaid adopted more flexible rules about the services that could be delivered and the modalities that could be used, and we saw flexibility in enforcement around some of our privacy laws and other regulatory steps to ensure that you all had the resources and the flexibility you needed to adapt the way you were serving your communities, on this really rapid and impressive time frame. That led to dramatic transformation in how patients use telehealth in a very short period of time. It's true across all types of care, but I think effects were sort of especially pronounced around mental and behavioral healthcare services and physical therapy and sort of other targeted services where telehealth uptake had looked very different pre-pandemic. Studies have consistently shown that many evidence-based interventions can be delivered over the phone and on virtual platforms with the same clinical effectiveness as receiving those services in person, and with greater patient satisfaction as patients sort of prefer receiving services in their home and sort of avoiding logistical barriers to care. So our challenge now is very much to learn from what happened over the last year and rapidly figure out how to incorporate those lessons into our payment system and other policies going forward. And so I think there are at least three key questions for all of you as you think about this work. First, and I think most foundationally, where is telehealth adding value in ways that will persist beyond the pandemic? Where have we seen a transformation towards higher quality, lower cost care because of the availability of telehealth and remote monitoring services? And how do we measure that quickly as things begin to return to normal so that we have the evidence we need to make decisions into the future? I think part of this is certainly a question of costs, but it's also about patient outcomes and patient experience, and really what the value proposition looks like. I think we all have our hypotheses about places where telehealth has really changed the value equation, but I think we have this sort of short window to back that up with data. And so that's my first ask to all of you, is to think about what you see in your own data, what you see in the collaborations you have with payers, to tell those value stories and help us learn those lessons about, again, like where the real value proposition has been over the last year. The second set of questions are around the sort of barriers to telehealth access and what that means for equity. it's intuitive and well documented that underserved populations have less access to telehealth. And all of your institutions, I'm sure, took steps to combat that and try to ensure and build that access during the pandemic. And the question now is what worked and what didn't work, and what can we as a system and as policymakers learn from those experiences. Telling the stories and backing them up with clear data is critical as we, again, try to think about bridging some of these equity gaps going into the future. And I hope you can spend your time together really diving in on these questions of equity and reaching some degree of consensus on what it takes to deliver telehealth services equitably. I think we are also, as a system, or at least should be really interested in the converse. Are there ways that telehealth may have actually helped close equity gaps that predated the pandemic? A lot changed about how Americans receive healthcare services very, very quickly. And are there lessons from this dramatic transformation in care delivery that improved our outcomes on equity measures? And what does that say about what we may have been doing wrong before and how we can fix it going forward? And I think really probing those lessons is critically important. The third set of questions that are on my mind is what's next? Where did you encounter roadblocks in delivering care remotely in ways that we should try and solve, not just for the next pandemic, but for the permanent delivery of high value care? I think these questions are probably especially acute around areas of remote monitoring. What technologies do we need that we don't have today? How can we build patient acceptance? How can we build provider acceptance of some of these tools and technologies? But I think it applies more broadly across your systems as well. It drives critical questions around where we should be investing to drive continued high value innovation in the telehealth space. I think we all share a vision that if we do this right, if we learn the lessons of this moment together and implement them quickly, telehealth will increase access, improve quality of care, and reach vulnerable populations, including those living in rural areas or who otherwise have trouble sort of accessing in-person care. I very much look forward to continuing to work with you to achieve those goals. I think this is a very exciting moment as we look to what the sort of future of telehealth and healthcare more broadly holds. And I think I commend you all for getting together to have these conversations and very much look forward to the learnings that come from it. So I think with that, I'm happy to take some questions.
Thank you so much, Kristen. Really appreciate you taking time. I will ask the first question. How do we deliver the data to the administration? We have studies underway. For example, 3 of the systems in the Alliance for Connected Care have an ARC grant, and we've asked if we could have preliminary findings that we could share. There's others that we sort of have a data book of systems beyond just the Alliance for Connected Care, as well as ACOs and some physician practices. It's not necessarily published peer-reviewed data yet, but it does tell a story. And then we also, as I was saying earlier, we have SNF transfer data, so a reduction in SNF transfers and an increase in transition code billing, which is correlated with a reduction in hospital readmission. We have better no-show statistics so that people are adhering to their care plans and seeing their doctors when they should. So we have, I would say, messy data, but in aggregate shows a trend towards let's say cost savings. And then we also have access data, more people accessing behavioral health, telehealth contributing to fixing the maldistribution of behavioral health specialists. So I'm wondering, what should we do with it? We've taken it to Congress and we've done, a Hill briefing for committee staff, et cetera, but who do we take it to?
Sure. I mean, so on some level, you know where to find us. CMS sometimes feels like a black box, but they're just people, and they're interested in this work. I mean, you certainly know where to find me and my team, and the people at CMS are very, very interested in these questions. And, they all know each other. And so to the extent there's work you want to do with the agency to talk them through some key findings, like by all means, reach out and make it happen and sort of initiate those conversations and those sort of initial learnings. Like not everything has to be a peer-reviewed study to matter to policymakers. And I think sort of sharing those key lessons informally is really important.
That's really helpful because sometimes academia and policymaking aren't matched up on their timeline. So we are fighting a perception of overutilization and fraud that has persisted for a long time, and we never had the data to show that it wasn't true. And so we're working really hard to show that telehealth is not uniquely subject to fraud. And we have been, we talked to the OIG's office, and we're really pleased that they have fraud studies underway. One thing I just want to mention, since we have you, is we do have misbilling because telehealth exploded. People don't necessarily always know how to bill it. So I just want to note that if you see big headlines that say, $20 million in whatever, like false claims or something, a lot of it is because people just didn't know how to bill, and they didn't want to use their, home address, for example. So we're going to hopefully call on CMS to try to do more training and more technical assistance on how to bill, so we combat some of that. But then also we're happy that the OIG is actually looking into fraud levels, because we think that they're the same as in person. So the other thing is on equity, we have been very disappointed in the percentages of minority populations that are actually utilizing telemedicine. It is still a struggle. So we would love to have any suggestions and suggestions from everyone on the phone on maybe we need to produce, a call to action and come to you with that on how we increase it, because it really can facilitate access. And I see that Christina Nyquist has a question. Christina, make sure to say where you're from.
Sure. Thanks so much for taking the time to join us. Really appreciate it. I actually am a newly at Tufts Harvard pilgrim, very excited to join the organization. And the question I wanted to ask after, thanking you for all the really important enhancements to ACA and the big changes, positive changes that we're seeing there, is around the audio only portion of telehealth. We've talked about underserved populations, and one thing is that helps these populations is audio only health, because it does not require broadband and some of these other infrastructure issues. And I just wanted to get your guidance and perspective is, as we're talking about the importance of being able to use the risk scores associated with audio only, what sorts of information would policymakers find useful as we start talking about that? Thank you.
Yeah, it's a great question, and I think you're sort of like hitting at an example of like great encapsulation of the challenge of this moment, which is we did something in 2020 that we had never done before, delivering a meaningful volume of healthcare services that were, clinically meaningful on audio only platforms in ways that we had never done or contemplated before. And so to some degree, I think we don't know what we don't know about what that looked like and in terms of the way people access care, and you all do. And so if if there is information in your records that makes clear that in a normal year, 80% of people who had diabetes in the prior year would have visited, would have had a certain type of clinical encounter. And then in 2020, it was only 30% or whatever, like those kinds of comparisons, I think are very useful stories to tell. And they're things that you all know that we don't, about exactly how patients use the service. It's not as if we went into it with like a clear theoretical model of what audio only telehealth would look like. We just like dove in because we had to in early 2020, and now we need to piece together the story. And I think, you all are really well situated to do that.
Great, thank you. Okay, we have 3 minutes, so I'm going to ask you one last question.
Great.
Another perception that we're fighting against is that there are a lot of virtual only providers out there. In fact, telehealth is largely done by providers that have brick and mortar and are doing telehealth visits in addition to in-person visits. So we do have a problem thinking about payment parity, because people say, well, if you're virtual, if you're not, it's lower cost to do telemedicine. But in fact, it is integrated most of the time. And I think that my personal opinion is that telehealth should be integrated with in-person care. Is there any discussion of about how we pay for telehealth fairly?
Yeah, so I mean, I think that is the critical issue in certain ways. I mean, I guess one thing that I would say would encourage people to be thinking like not just about what is happening at this moment, but like about what the value proposition is for telehealth 5 years from now. And so if what we are saying is there is a real value proposition to delivering a certain set of services in this way, and we should all be investing in delivering services in those way, then like that means that not only should payers be paying for services, but providers should also be like adapting their cost structures to deliver services there too. And so, I do think it is bigger than just thinking about like there is a lot we can learn, as I've said many times, about what happened in 2020. But to the extent what we are trying to do is drive the long-term value proposition that sort of goes on both sides, and what the long-term value is for patients, and what the what the cost structure should look like if this really does become an integrated part of our system. I think the way these conversations very much like aspire to see.
Your message of demonstrating value is really helpful, because as a lobbyist, sometimes I hear people saying, well, the government's not going to take away a benefit that they already have given people. And I say, yeah, but they can and they will, unless we can show that it was, a good use of taxpayer dollars and increased access, maintained or increased quality, and potentially reduce costs. So it's important for us as advocates and as practitioners using telehealth to demonstrate its value. So thanks for that call to action, Kristen. And we look forward to more communication, and thanks for your time.
Great. Thanks, everyone. Appreciated it.
Thanks. Okay, so we have heard from the Biden administration, and now we're going to move on to hearing from members of Congress. We are excited to be presenting 2 awards today, one to Senator Wicker and one to Chairman Mike Thompson. Senator Wicker is currently on the floor with voting, but hopefully will be done shortly. But I am so pleased to introduce a constituent. We are very pleased to have Dr. Saurabh Chandra here with us, who is going to talk about the important work that the senator is doing. And Dr. Chandra is the Chief Telehealth Officer at the Center for Telehealth at the University of Mississippi Medical Center. So obviously Dr. Chandra is very familiar with Senator Wicker's advocacy and promotion of all of the great things that the university is doing. So thanks so much for being here, and I'll turn it over to you.
Thank you, Doctor. Thank you, Krista. Can you hear me?
Yes, yes.
Okay, wonderful. So it's an honor for me to introduce Senator Wicker, a highly respected stalwart and a great proponent for telehealth. Mississippi is one of the earliest adopters of telehealth, and our success in telehealth for improving the health of the state, and especially those that are living in rural and underserved areas, parallels with the extraordinary support provided by our state representatives in Congress. And amongst them, Senator Wicker certainly stands very tall for his unwavering passion and enthusiasm for all things telehealth. I had the privilege of meeting Senator Wicker in person a few weeks ago when he stopped by the Center for Telehealth at UMMC together with Commissioner Carr of the FCC. That is when I came to know and realized that Senator Wicker's passion for telehealth goes far beyond introducing successful legislation in Congress. He's a true visionary and understands what telehealth can achieve at the ground level. The legend is that when Commissioner Carr was confirmed by the Senate in 2018, Senator Wicker brought him to Mississippi to see how the remote patient monitoring program of the Center for Telehealth at UMMC can change lives of diabetic patients. And that actually triggered a change in focus for Commissioner Carr. And he started thinking more along the lines of bringing connectivity to the homes of the patients in addition to just the brick and mortar hospitals. And how that impacted later on can be understood by the fact that when the pandemic hit, because of the change in focus and allowing connectivity and focusing on increasing connectivity in the homes of the patient, we as physicians, as telehealth providers, were able to take care of the patients in their homes during the pandemic. So Senator Wicker is a member of the Senate Telehealth Working Group, has worked to introduce bills to expand telemedicine services and improve access to telemedicine over the last several years. While Senator Wicker's contributions to the growth of telehealth are too many to list in a short amount of time, I would still like to highlight a few. In 2015, Senator Wicker convened a hearing entitled Advancing Telehealth Through Connectivity in his role as the chair of the Subcommittee on Communications, Technology, Innovation, and the Internet on the Senate Committee on Commerce, Science, and Transportation. The hearing examined ways to advance telehealth technologies nationwide, particularly in rural areas. The hearing also explored challenges facing many health centers and healthcare providers and patients attempting to take advantage of innovative telehealth technologies and applications. And it also featured testimony from Dr. Christy Henderson, the Chief Telehealth and Innovation Officer of UMMC at that time. And the hearing blew open the door for telehealth and expanded the jurisdiction of the committee to preside over telehealth issues. In 2018, Senator Wicker was successful in changing telemedicine law to remove outdated federal restrictions that limit Medicare from reimbursing for telehealth services. The House and Senate passed a budget deal that included the Chronic Care Act of 2017, which contained key provisions authored by Senators Wickers and Schatz that allowed Medicare to cover more services via telehealth for treating chronically ill patients. In 2020, Senator Wicker was one of the go-to senators to figure out what flexibilities in policies and regulations were needed to ensure Americans had access to health care via telemedicine throughout the pandemic. He has also worked to include a provision in the CARES Act to expand telehealth services for Medicare patients. Senator Wicker has been a strong supporter of UMMC as a leader of telehealth across the state and nationwide. In April 2015, Senator Wicker praised UMMC's telecommunications teams for providing emergency assistance and specialized care via telehealth across the state, and for the telehealth programs giving doctors in small rural hospitals the ability to turn to UMMC specialists for consultations in a matter of minutes. In May 2017, he highlighted our work and the testimony given on the Chronic Care Act as well. In October 2017, we were honored when Senator Wicker participated in a press conference to announce the designation of UMMC as a Center of Excellence for Telehealth by HRSA and HHS. As recently in January 2021, Senator Wicker chaired the FCC award of $2.377 million for UMMC for a connected care pilot program to provide telehealth services for low-income Americans living in rural areas. Most recently, he visited us a few weeks ago and brought Commissioner Carr along with him and gave us the opportunity to showcase our current and future endeavors. On behalf of UMMC, I'm truly honored to present the first ever Digital Health Congress Leadership Award to Senator Wicker. And if he's here, I would like him to say a few words. Thank you.
Well, I am indeed here. I'm speaking to you from my office in the U.S. Capitol. We're having a series of 4 votes, and we're now in the second vote. I've voted on that one, and the bell will ring in a few moments, and I'll go vote on the 3rd and 4th. This is the award, which I very much appreciate. I accept it also on behalf of my staff who are so talented in getting into the weeds of telehealth and technology, science, and understanding the ins and outs of this, and helping me to put our legislation into words that actually work. And thank you, Dr. Chandra, for mentioning my work with the University of Mississippi Medical Center. I was delighted to tour the facility again just a few days ago with the commissioner from the FCC, and so I'm certainly glad to be with you again today, and you honor me in an overgenerous way by giving me this award. We know that the internet has revolutionized so many things: correspondence, healthcare, the delivery of news, but it's also doing the very same thing for medicine, and thank goodness it has. A lot of Americans don't have the location or residence to see a doctor as often as they'd like. My state is a rural state. Actually, most of the 50 states have a good deal of rural area, and telemedicine is helping us reach that vast heartland of America where so many people cannot be present with a healthcare provider as conveniently. But of course, there are still a lot of places that are not even served by the internet, and that's why we're trying to build out broadband. We had a rural auction that is now in the works, and we're building out 5 times as fast as we were before that auction in many places, including in my home state of Mississippi. But also, I was part of a press conference today where 3 colleagues and I put forward a program to make broadband, to add another over $45 billion in broadband build out as part of the infrastructure plan. Thank you for mentioning the Connect for Health Act, which was the legislation placed in the COVID relief package. Since the bill's package, telehealth visits have increased by 50%. Real results. The bill provided $200 million for the FCC's COVID-19 telehealth program, followed by another $250 million last December. And these investments will help fund telehealth grants across the country to connect providers and patients with each other. And then just last week, the FCC announced that they will begin accepting applications for a new round of telehealth grants. So again, thank you for this kind award. And again, I accept it on behalf of the wonderful young people who work for you, the taxpayers, and who helped me get the expertise to put the thoughts into legislation. I look forward to visiting with many of you again and relying on your knowledge and your expertise in the medical field and the telemedicine field to make this successful in the future. So thank you very much, Dr. Chandra, and I will yield it back to you and thank all of you for clicking on and participating today.
Great. Thank you.
Thank you.
Thank you. Thank you, Dr. Chandra. Our next award is for Chairman Mike Thompson. He is not quite on yet, so I'm going to go ahead and go back to finish. I'm going to take this few minutes that we have to go back to my slides. The congressman was scheduled to come on at 1 o'clock, so I'm just going to take a few more minutes here and share my slides. Okay, so as I mentioned, we have made cross-state licensure and licensure portability a priority of ours this year. And this is the map of the states that introduced bills on cross-state licensure. So there was a variation in approaches. The Arizona legislature included a provision in HB 2454 that would have simply recognized out-of-state providers. So if you had a license in another state, you could practice in Arizona. This was modified through the legislative process to become a registration process. So if you register with the Arizona Medical Board, you can practice in the state of Arizona without an Arizona license. Registration processes are becoming a sort of a trend among states, and Maryland Governor Hogan introduced a registration process. The Uniform Law Commission, it has been drafting a model law on telemedicine and is relying in part on a registration process in their licensure portability section. Idaho is probably the most progressive state on cross-state licensure, and they basically said you have to be in good standing and hold a good valid license from another state to be able to practice in Idaho. What we've been doing, the Alliance for Connected Care, is trying to advocate on the registration process that we don't recreate the licensure process. So we don't want to create, hefty fees or redundant background checks, for example, so that the registration process is essentially a verification that you have a license and that you are practicing there. So we hope for light touch registration process. I will say the registration process does have some political challenges, and that is that a legislator or governor is telling their practitioners that others can come into your state, but you can't go into others' states. So one argument against that is, well, if enough states do registration processes, then it does become like a licensure portability compact. We are, while registration processes are certainly a step beyond where we are today, which is licensure in the state where the patient is located, we are advocating for what we were calling medical excellence zones, which essentially is an area that providers of all kinds can travel within that zone and treat patients. So use telemedicine. If you're home visiting, for example, you can't establish a practice without a license in the state, but that you can treat patients in other states in the zone without a license. So we've built in a lot of guardrails in our proposal, a registry to make sure that medical boards know which providers are practicing in their state, a coordinating committee between the medical boards for purposes of coordination on discipline. But honestly, we really want to keep the consumer and the patient top of mind here, that that licensure portability really is about giving patients access to providers that may not be within their state lines, and allowing that without having to get in the car and drive far. So at the federal level, both the state and the federal level, we have come up with consensus principles. And the reason why you see the date here is because we're trying to convey that these are never final, that this is a living document, and that we want people to sign on to this, and organizations to continue to sign on to this open letter to state and federal lawmakers, basically saying that that patients should be able to travel across state lines, and we want patients to be able to travel across state lines, but that there's significant barriers with the way that we currently license providers. So we essentially call on state and federal policymakers to work on this issue, and as evidenced by this past legislative session, they are working on this issue. So you'll be seeing more from us on this topic. And if you're interested in the Medical Excellence Zone, you can go to our website. We're working in the DC, Maryland, and Virginia area, the New York tri-state area. We have had some conversations in the western part of the country, but we think there's a lot of room for growth on licensure portability, and the pandemic has really shown that this can be done. I do want to go back just a couple slides, since we have a couple more minutes here, and talk a little bit more about these 706 bills that were introduced across the country and these regulatory actions. These fall into a few categories. We really have had robust discussions this year about scope of practice, who can practice telemedicine. Obviously, our position is that any medical practitioner or clinical practitioner that is licensed in the state should be able to practice their area of medicine through telemedicine. And another area is definitions. What is the definition of real-time versus asynchronous care? There's a lot of discussion about what is telehealth, and unfortunately it does vary state to state. There is discussion about Medicaid reimbursement. Some states had originally replicated some of the Medicare barriers to reimbursement, and in some legislative sessions this year, there was robust discussion of lifting any remaining originating site or geographic restrictions, as well as how do we reimburse for remote patient monitoring in Medicaid. So Medicaid definitions, the cross-state licensure issues, and I mean, the list goes on, but I would recommend that, if you're interested in telehealth policy, to look more into what happened this session in your states, because there's always more to be done. So we have Chairman Thompson on the phone right now. So I am going to go ahead and introduce Dr. Glenn Chertoff from Stanford University, who is going to present the award to Chairman Mike Thompson.
Thank you. Thank you very much. I'm now on video. I've got my mask on, working in the hospital. It's an absolute privilege and pleasure to present the Digital Health Congressional Leadership Award to Representative Thompson. I'm a member of the faculty, the full-time faculty at Stanford University, a professor of medicine. I'm a kidney doctor, and our practice and the practice of virtually all of the physicians at Stanford Healthcare has been aided by the tremendous efforts of Representative Thompson over not just the time of the pandemic, but many years. I was quite inspired to learn of Representative Thompson's extensive and long-standing interest in telehealth dating back more than a decade. He's been founder and co-chair of the Congressional Telehealth Caucus, and has introduced a series of bills, including bills to aid in telehealth dating back to the early 2010s. The ability to provide care to persons in rural areas and to other disadvantaged populations has been an enormous asset to the health of our region. I practice at the Stanford campus, but also have an outreach practice where I have the privilege of caring for a number of Representative Thompson's constituents, many of whom come from underrepresented, disadvantaged groups who have difficulty accessing the highest quality healthcare, which we aim to deliver at Stanford. And because of the capacity to provide telehealth visits, we've been able to provide care to persons throughout the 5th Congressional District. And the work that Representative Thompson has done has really expanded access to patients to excellent care all over the country. As a kidney specialist, I'm well aware, I look after patients with kidney disease, hypertension or high blood pressure, and also those with kidney failure and those who require dialysis or who receive kidney transplantation. And I know there are many regions in the country where there's very limited access to subspecialty care in rural areas, not only in this district and in our state, also as we heard in Mississippi, in many other states around the country. And the ability to access subspecialty care for persons basically anywhere in the United States is a tremendous benefit. And we owe much of that to Representative Thompson's decades-long work as an advocate for telehealth. I'm personally very grateful to you. I know that my colleagues at Stanford are very grateful to you. And we look forward to continuing to work with you to enhance telehealth access for patients throughout our region and beyond.
Well, Doctor, thank you very much for that very kind introduction. And thank you to you and to your entire group for your focus on telehealth and the understanding of how important that is for us going forward. And you're right, I've been working on this for a while. Matter of fact, it goes back to my days in the California State Senate when in the middle 90s, I authored a bill. It was passed and signed into law. It was the first bill in the country to allow for non-face-to-face reimbursements to providers. And that kind of got telehealth kicked off and off to a good start. So when I came to Congress, it was understandable why I wanted to pursue that. I believe it's very, very important. So it's an honor to be with you today. It's an honor to be recognized, and I have my award. Thank you very much. And it's a beautiful award that will be displayed in my Washington, D.C. Office. So anyone who comes in will know that I support telehealth. And the benefits of telehealth, it's efficient, it's cost effective, it helps people in rural and underserved communities get care, it saves money, and that's more important now during COVID than it has been in the past. And as we know, things have advanced, so it's not just rural and underserved communities. Telehealth has great value in every community across the country. There's been more telehealth in the last 9 months than there's ever been before. And just interestingly, before COVID, there were 13,000 Medicare patients a week receiving care through telehealth in California. Since COVID, it's been 1.7 million Medicare patients per week. So we're seeing firsthand not only how well this is working, but how popular it is. And interesting statistic that I saw the other day is that telehealth has reduced the no-show appointments by half. So that's important, not only for patient convenience, but for provider convenience and efficiency and cost as well. You know, Sutter Health told me that in my district, that on the last quarter of 2020, that providers saw between 4,500 and 4,800 telehealth or video visits per day. And now they tell me that telehealth accounts for 16 to 17% of all the healthcare that could be done virtually across all of Sutter Health. So we see all kinds of examples as to why it's working so well and why we need to keep it going. You know that the first COVID relief package had my bill in it that waived the existing telehealth restrictions during a coronavirus public health emergency. It was supported on a bipartisan basis, and it allowed seniors to get medical care over through telehealth. And CMS took advantage of that authorization that my bill provided, and it's been just this huge help for Medicare beneficiaries. And once the healthcare crisis is over, we want to make sure that we continue to see this accessibility and see the gains in the future of telehealth. So that's why I've co-authored, or I've authored another bill, a bipartisan measure protecting access to post-COVID-19 Telehealth Act. Watch for it. It's coming to a location near you soon. And the legislation would continue the expanded use and eliminate those restrictions. And again, something that's incredibly important. You know, the bill, just, you know, so you know, it would permanently enable Medicare beneficiaries to use telehealth services, even if the patient isn't located in a federally designated rural area. And it permanently enables Medicare beneficiaries to receive telehealth services at home. We know that a lot of patients would prefer this, and it works for them, and it's convenient and effective. It also authorizes HHS to expand telehealth and Medicare during all disasters and all public health emergencies. And it allows seniors to get telehealth services at federally qualified health centers and rural health centers. It extends the existing telehealth flexibilities for 90 days beyond the end of COVID emergency, so we just don't cut folks off cold turkey. It's a bipartisan bill. It's been introduced by over 200 of the leading health organizations, and it's incredibly important that we make sure that that we get this bill passed. It is, I'm very pleased to tell you, I think this might be new information to you, but next week, the Committee on Ways and Means, the committee that I'm on, the healthcare subcommittee of that committee, which I'm on, will have a hearing on telehealth. It is the first ever hearing on telehealth by Ways and Means. So this is going to be important. And I just want to finish up by reminding folks that it's not enough to have access for everyone. We need to also have availability for everyone. And so that means expanding internet, expanding broadband, so everyone can easily get online to access this important service. And this is important to note because of the president's infrastructure bill that we're working on right now. This has a massive expansion of broadband. And anyone who needed healthcare coverage during this pandemic and wanted to use telehealth, but didn't have access because of poor broadband. And they know that they were disadvantaged when their neighbor down the street had that access. And the same thing could be said about distance learning of your children or grandchildren. If they weren't hooked up to and able to access service, they got less of an education than their peers that had those services. So we need to make sure that we focus on this. In my home state of California, about 1 in every 5 people don't have reliable enough broadband to receive telehealth services. And that's something that we've got to address. And that's why this infrastructure bill is so important. So again, thank you for the award. And just know that telehealth, I've been working on this for almost 30 years, and I'm not going to stop now. It's still, it remains one of my top priorities, and it will. So thank you for the award. Thank you for your help and commitment. And I look forward to us seeing some good victories in the future.
Chairman Thompson, can we ask one question? This is Krista Droback from the Alliance for Connected Care.
Sure.
What we have been struggling with the conventional wisdom on Capitol Hill, and we think unfounded, that telehealth might lead to overutilization or to unique, that it might be uniquely susceptible to fraud. And we have data that shows that telemedicine is actually substituting for in-person care and not creating overutilization. And we've also worked with the OIG to clarify to staff and members on Capitol Hill that the telemedicine so far during the pandemic is pretty much on par with in-person care in terms of fraud, so that we don't have a lot of extra fraud. What I'm worried about, last month, the Energy and Commerce Committee had a hearing, and I heard, we heard from a lot of your colleagues these sort of repeating of what we believe are misconceptions about fraud and overutilization. So I'm worried that we might hear that again at the hearing in a week, and would love some guidance from you on how we can get through and with our evidence in the pandemic, because finally we actually have data, which we didn't have before. So would love your guidance and thoughts on that.
Well, you're absolutely correct, and I think you want members of Congress to be concerned about this issue, and we're going to need the data that you have. And we'll bring these data forward, but I think it's important that Congress does focus on this to make sure that this isn't an issue. It's it's kind of like doctors are kind of like members of Congress. There's good ones and there's bad ones. And as you know, that some docs have cheated, and in the conventional type of healthcare reimbursement. So to think that some wouldn't in telehealth, I think would be naive. We've got members of Congress that don't act appropriately as well. So I think we need to have guardrails in to make sure that this thing doesn't come to fruition. So I wouldn't be afraid of that. I would, I think we need to own it and need to figure out how to make sure it doesn't happen.
Well, we're lucky that we do have data now. Before, we were trying to dispel those myths without anything. So we're going to continue bringing that to your colleagues on Capitol Hill.
Very good.
So thank you so much for joining us today, and we look forward to another year of working with you to get this across the finish line.
My pleasure. It's great to work with you guys, and I look forward to continuing that relationship.
Great. Thanks again.
Thank you.
Thank you. Thank you so much.
Thank you.
So we have a few extra minutes before we have our first breakout session. So first, I just wanted to finalize, say, my last words on my slides, which were really about cross-state licensure. There is an enormous amount of work being done on cross-state licensure, and I hope that you'll join the breakout session tomorrow, being led by MedStar, that is specifically discussing licensure portability, so we can get more into the weeds on that. I didn't even have time to mention the advanced practice nurses licensure compact, which is new this year and allows for our MPs and others to practice across state lines, much like the RN compact. Again, there's a lot of registration process bills and others. So I hope that you'll join that breakout session tomorrow. But I did want to just ask before we move into our first breakout session, I consider the first part of this conference, the summit, to be about the state of play in Congress and at the state level, and is more about the political aspects of what could happen and what the barriers are than the rest of our program, which is a lot more about how do we take these operational barriers and turn them into policy asks. So I want to pause and see if there is anything that anyone wants to talk about related to the state of play and any of the politics around this and any of the prognosis for what might happen this year.